Good afternoon. My name is Bill Detmer, CEO of Unbound Medicine, and thank you for joining us today for the latest presentation in the Unbound Medicine webinar series. We've been providing these with our friends from Johns Hopkins for more than 13 months, and we're delighted today to bring you the latest installment with our friend, Dr. Paul Auwaerter, who, as you know, is a professor of medicine at Johns Hopkins University School of Medicine. And he's been at the forefront of this work in many ways. Number one, he's given us many webinars during the last year that have helped us keep up to date with both the clinical side as well as the prevention side. And he does work as the director of the Division of Infectious Diseases at Johns Hopkins and also at the Center for Environmental Infectious Diseases. So we're delighted to have Paul again today to talk about where we are and where we're headed in the months ahead. The format of today's webinar will be mostly conversation, questions and answers. Paul has provided some background on vaccines, issues of hesitancy, issues of variants, which we will hear at the beginning, and then we'll move to question and answers. Many of these questions were submitted by you, and thank you very much for those contributions. We may not be able to get to all of them, but we very much appreciate you engaging on these topics. So with that, let's get started. Paul, what do you have to say about kind of where we are in aggregate? What is it, 16 months in from the initial phase of this virus?
Yeah, Bill, thanks so much. And I think many of us are feeling some cause of optimism, especially as people are increasingly immunized, but at the same time, the COVID-19 remains a global pandemic. And I think many of you may be hearing stories, especially in some countries such as India, which is experiencing a tremendous surge, and recorded cases are probably far below the actual in that particular country. But the Johns Hopkins real-time data map continues to show high incidence rates in many countries and continents, North and South America and Europe. And as I mentioned, only because India's population is so large, it doesn't look very important, but as we're discussing today, India now has the highest numbers of cases known of COVID-19 on a daily basis. In the United States, many people have asked me when is the pandemic over? When can we take our masks off? The Centers for Disease Control is revising mask mandates outdoors. But as you look across the country, it is variable. And what is considered low enough to return to normal, I think, is a matter of some debate. But figures that I've typically heard are numbers such as less than 1 or 5 cases per 100,000. You're just like, well, that's per day. And that's a hard number to maybe wrap your head around. But what that probably means is that on a given day, less than 10,000 cases of COVID-19 may be occurring in the United States, of course, spread out. So as you look at this map, where those rates are very low are denoted by green and to some degree by yellow. All other colors all the way up to the purple are more concerning. So that means your chances of encountering the virus out in public or meeting people is considerably high. Michigan, for the past several weeks, has clearly had a big surge. In fact, their hospitals are very much stressed. And the pandemic has shifted within the United States, and this is normal as over half of population has now received at least one vaccine, especially older populations who are first immunized. But kinds of infections have tilted more towards younger people. Bill, we used to say 20% of people would need hospitalization probably, but in a younger amount that has probably declined to 1 to 5%, but it's still important because you have lots of young people that may not be taking as great care, and just by sheer numbers, they're comprising more of the hospitalized populations.
Thank you, Paul, for that kind of wrap up of where we are right this minute. Let's move on to talking about variant viruses. This has become more of a theme in the last couple of months as new variants have been spreading across the globe, versions from the UK, from South Africa and Brazil, or at least where they were originally identified. Could you give us an update on where things stand with viruses, virus variants, and how they affect treatment and vaccination?
Yeah, Bill, I think the United Kingdom sort of set the pace by doing routine sequencing of viral isolates in 2020. And for that reason, they were really the first to ring the alarm bell in the fall of 2020 when they really had rushed to get vaccines into their population, and also proceeded with their third lockdown in the country. And the reasons for that have become more clear because the most studied of these variants is the so-called 117 first described in the UK. Not at all clear that's where it started. But even in the United States, as our sequencing efforts have gotten more robust in the past few weeks, you can see the 117 has clearly become a predominant variant. And variants are just a normal consequence of any virus, especially an RNA virus. And I'm also impressed, as you see here, there's many variants, and then there are those that are labeled VOC, variants of concern, mainly because these appear to have changes in their spike protein that increase transmissibility. And that appears to be mostly due to a more prolonged viral transmission, and meaning that the viral loads, which we typically had thought might turn negative by 10 days in terms of infectiousness, in normal people might be 13 days. So that's a 30% increase. So people are more infectious for longer periods of time, and at least with this 117 variant, a suggestion that it's causing more hospitalizations. Now, as I've mentioned, there is a trend towards infecting younger people now, and I think that's really just because that's the population that remains susceptible. And many are worried that although the variants so far have caused some problems with vaccines, an additional curveball, a new variant, which is capable of immune escape from most of the vaccines, would be terribly problematic. And the only way we know to really decrease the emergence of new variants is by decreasing the number of infections, hence why there's such a push to try to immunize people.
Well, thanks for that, Paul. Obviously, variants will keep coming back into the story as we go forward here, but it would be great to hear how vaccine efficacy is panning out, and not just for the quote original strains, but also for the new variants that are appearing recently.
Yeah, so Bill, the efficacy of a vaccine is something that's no doubt important. It's often led to what I call my father-in-law question: which vaccine is best? Which should I get? And the point, unfortunately, is that we can't really compare vaccine trials. They were done at different times with different community rates of infection. So it's not particularly fair because none of these trials were head-to-head comparisons of vaccines. I think the key point that I always emphasize with patients is the following: that if you look at people who were in vaccine trials, they did an amazing job at preventing severe COVID-19 from mortality, and at least in these tens of thousands of people, no one appeared to have a vaccine-induced injury. So by and large, from the preliminary information, this, I think, exceeded all expectations and really have been embraced by all governments and public health organizations in an effort to protect people individually as well as for community health. And since all of them seem to work very well, the exception would be really with the particular variant first described in South Africa, the 1351, and to some degree, perhaps the one first described in Brazil and Japan, the P1, where the AstraZeneca vaccine is a little different than others. It doesn't have a 2-proline motif in its spike protein, whereas all other vaccines use this 2-proline motif. So it's organized a bit differently and in a different vector. South Africa is no longer using AstraZeneca because its predominant strain, its efficacy was unfortunately low. But for example, the Johnson & Johnson vaccine was just resumed in South Africa because it was effective. And indeed, that's where this trial was actually had a significant part of its clinical trial carried out was in South Africa. So from a variety of studies, and I just have one here from a letter published in the New England Journal, taking sera from people who have been immunized and testing them against a variety of these variants, it appears all three of the major vaccines being used in North America at this time appear to have sufficient activity by pseudo-neutralization assays. However, there's a sense that to get a sufficient titer of protective neutralizing antibodies, it's best to get both doses. A number of patients have asked me, oh, I don't want to get the second dose. I've heard the first dose is sufficient. I think the message, though, is if you're faced with one of the variants, you're going to be more likely to be protected if you get the second doses of the mRNA vaccines by either Pfizer or Moderna. The Janssen vaccine, of course, is just a one dose administration there.
Thanks, Paul. That brings a question in from one of our contributors who asked really a kind of a basic science question, and you alluded to it, but it is if we look down the road to how this virus might mutate over time, is there something special about the mRNA vaccines that make them more likely to have efficacy against variants, or is this just kind of a duel with nature that may take a course in any direction depending on where the genetic mutations occur?
Yeah, Bill, I think it's uncertain. I'll tell you some pieces of information that at least have impressed me. There's a vaccine candidate by Novavax, which uses an immune adjuvant, and they've generated some of the highest antibody titers, but preliminary evidence suggests it may not work quite as well as the mRNA vaccines. Now, why this is may not be exactly known. The RNA vaccines are processed a bit differently, including in follicular dendritic cells. So perhaps there's more robust T cell responses, and you're getting a slightly different set of activity compared to a protein subunit vaccine or some of the adenovirus vectors. And again, I'm not even sure there's as much difference because these in vitro assays that just do pseudovirus neutralization are just essentially a type of surrogate It's really only looking at immunization rates among vaccine recipients that I think the tale will be told. And we need to marry that with the viral variants. So it's not an easy thing to assess. I think we're accumulating information, but a lot of it I think we'll only know, unfortunately, weeks later because of the complexities of trying to get at that answer that would truly be helpful to know.
Mhm. Yeah, I mean, in some ways, it's one of the miracles really of this era that we have so many different candidates with different mechanisms and have the ability to compare and contrast and bring to bear, different vaccines at different times for different variants if we need to. That's quite a story actually of this pandemic. Why don't we move on to talking about, what the difference vaccination makes? And I know that you have some interesting slides on that.
Yeah, so there are some things that I think if someone's on the fence, uh, just looking at your own individual health, your family's health, these vaccines, even when launched into the real world situation, appear to work as well as we thought they did in the preliminary results from the clinical trials. For example, some initial data organized and published through the Centers for Disease Control prospectively followed almost 4,000 people and had weekly swabs looking for evidence of infection. So this is a bit more intensive than many of the clinical trials. And interestingly, here, for once you got fully immunized 2 weeks or more after your last dose, people were 90% less likely to get coronavirus. So this is very much in keeping with those overall 90% plus efficacy rates of the mRNA vaccines. But importantly, whether you get the viral infection or not, as long as it's mild, I think most of us would take that if it could really reduce severe infection and death. And it does appear that these vaccines are beginning to do this. Israel is perhaps one of the countries with the highest rates of their population immunized. And this is some national data, as they have a national health database, and cooperating with Pfizer, studied the impact of their Pfizer mRNA vaccine, which was mostly utilized in the country. And this was in face of widespread 117 variant of concern. And you can see here over a 2/3 drop in the severity of cases, hospitalizations, and overall cases just in the first 2 months of immunization. Now, they had immunized more, but this gives a very hopeful sign. And indeed, many of the pandemic measures, social mitigation, otherwise, have now been relaxed in Israel because here we are. This is now 2 months even from these data, and the number of cases have continued to fall.
Yeah, so that really, tells a story that getting vaccinated matters, and maybe from what you said earlier, which one you get vaccinated with less important than getting at least one of them, one of the types, and then doing the full schedule for the type that you get, either 1 or 2 dose, whichever one that is. I don't know if this is a good time to ask the question, but there have been some side effect issues related to different vaccines, particularly related to thrombosis. And I know that you'll mention that the Johnson & Johnson vaccine has been on and paused in the United States and then restarted recently. Can you talk a little bit about the mechanisms of those side effects and how they are different between the types of vaccine vehicles, because it's pretty interesting from a science point of view as well as a public health one.
Yeah, I think that's right, Bill. So far, of course, millions of doses of the mRNA vaccine have been distributed, and as of yet, there doesn't appear to be any kind of signal for inappropriate thromboses or more thrombocytopenia than would be otherwise anticipated from background. And most focus there has just been with the side effects, which can, for some people, land them in bed for a few days and then remit. And there have been very rare anaphylaxis issues, mainly related to polyethylene glycol, which gratifyingly have been very rare, and no one has died from that. But these extremely rare side effects in terms of allergy, for example, are occurring at about the same frequency with the J&J vaccine in terms of thromboses. Now, we don't really know the mechanism. What brought it to an initial pause was 6 clots, but of an unusual nature with cerebral venous sinus thromboses in women that appeared to be on the younger side. So there was about a 1 in a million chance of developing such a thrombosis. And I think the FDA and the CDC came to the conclusion, and although the panel with the Advisory Committee on Immunization Practices was split a bit, they did vote in favor of proceeding because I think the overall benefits of the vaccine outweigh the rare risks. And they included a warning just regarding the clots. So with a 1 in a million chance, that is indeed low. And there's some people that don't like needles. They perhaps are too difficult to organize to get a second injection. So this sort of immunization definitely has a role. And it's very hard on an individual basis because people will say, I don't want to take a 1 in a million risk. But as you pointed out, our avenue for getting our country out of pandemic mode is to get as many people immunized as fast as possible. And so having additional supply and additional type of vaccine would be very helpful. This same issue has challenged AstraZeneca, which is a 2-injection vaccine, which was one of the first vaccines used in the United Kingdom, along with the Pfizer vaccine. And this was a handout sheet, a little picture of what was handed out in the Netherlands regarding this vaccine, because this one too appeared to have some unusual clots, mainly in women under 60, that it could include venous systems in the brain or splanchnic thromboses. And what they sort of put here was a risk of clots, as you can see, about 4 in a million. And you saw also risks of clots with women that use birth control, for example, or who smoke. Or, of course, if you actually get COVID infection, you can see the risks are thousands of times more likely, as you can see here. So it gives a little bit of a perspective why this has occurred. We don't know with the J&J vaccine, Bill. That was your original question, I think. There were a couple of reports published in the New England Journal that suggested with the AstraZeneca vaccine, it appeared to be a similar mechanism to heparin-induced thrombocytopenia. So you get this paradoxical clotting despite having low platelet counts because of antibody formation against platelet factor 4, or at least that's the hypothesis. So a part of the rationale is if anyone after the Janssen vaccine, for example, has unusual headaches, for example, or any suspicion for clotting, you don't want to use heparin there. You want to use one of the oral anticoagulation agents, such as gatroban or something of that nature instead.
Thanks for that, Paul. This is where the rubber hits the road, where trying to both do the best science we can and transmitting that information as widely both to scientists and to clinicians so they know kind of what the possibilities are at the same time to be able to communicate to the public about the benefits and risks in a way that's easy to understand and to process, is one of our biggest efforts. It's, our brains, I think, we have the cortical brain and the older old world brain, the amygdala oriented brain, more emotionally driven versus cognitively driven, and so it's always a tug of war between essentially those two things about what to do. Certainly, the science, as you say, bears out that these side effects, when they occur, are exceedingly rare, and the benefit far outweighs those risks. But that having been said, most of us spend a lot of time talking to people about, that classic question: what's the best answer that you have to somebody saying, I don't want to get vaccinated because of X? And so I know you have some things to.
Yeah, I do, and I'm not sure I know the best answer there, but the way how I sort of look at vaccine hesitancy, there are the people that are anti-vaccine, and that's a different category. But people that are hesitant, it's usually due to unknown issues, fear of something that's internalized that could change them forever. Of course, certainly the infection can do that. But it boils down to who do you trust? And those trust issues, I think, are important. I think for many people that look at the data, we feel comfortable, but that's not an easy thing to do without a lot of training and experience to try to filter something. So what I've generally told people are one or two things that maybe helps. First, over 95% of physicians in the United States have been immunized. So here's a group that I think can certainly interpret this data and judge whether it's to their benefit and probably their family's benefit to be immunized. And this is a very high percentage of group to be immunized. So if you trust your healthcare provider, your pharmacist, your nurse practitioner, your doctor, ask them. And I think if you trust their advice for taking care of you, they are not going to steer you wrong. So that's probably important. But you can also talk to friends and family and colleagues, because many people are afraid of the vaccine side effects, can make them ill for a day or two, and so on. And I think just getting some comfort level there can help as well. But Bill, certainly misinformation, which is so easy to promulgate on social media, has been just amazing in the face of this public health emergency. I dare to think what the polio epidemic would have been in the 1950s if we had Facebook, and the number of children that would be now partially paralyzed adults would be far different because of fears with the polio vaccine. The one that I find just most astounding is I've had so many parents of adolescents, young adults, kids in college, soon to be married, say, I'm worried that the vaccine's going to induce fertility issues. And this sounds sort of like an Amazon Prime video series. And indeed, it was such a series that some medicine somehow started to cause fertility issues. And how this all started, interestingly, traces back to late last year in a letter to the European FDA, essentially, by two propagandists who said that the spike protein contained genetic sequences similar to a protein, syncytin-1, used in the human placenta. And really the similarity just, it's under the myth column, but just to point it out, it's only a very small amount of genetic code. It's by no means that similar. And what I've generally told people is it's as if you had two phone numbers. The two phone numbers differ except for the number 7, but if you dial each number, you would expect to get the same person, and that's not likely to be the case. So what we know so far is there is no evidence to suggest fertility effect of males or females. New England Journal just earlier this week or last week, I should say, published an article looking at 35,000 pregnancies of people that had been immunized versus those that were not. And there was no difference in any kind of abnormalities during the pregnancy, fetal malformations, et cetera, in those people that were immunized or not. And of course, pregnancy is a risk factor for severe COVID-19. So that's important point number one. Number two, COVID-19 infection itself doesn't appear to affect fertility. So why would the vaccine? And the third is in the Pfizer trial, 12 people had a successful unplanned, probably pregnancy, or who knows if it was planned or unplanned, I should just say, but had a successful pregnancy versus 11 in the placebo group. So I find that hopefully this kind of information is helpful because this is a very potent reason for people not to get the vaccine when it's completely erroneous. Some other ones are, of course, that the vaccine will give you COVID-19. This is very similar to the argument with the flu. And the fact is there's no replicating virus of any kind to produce infection. What you may experience are well-acknowledged vaccine side effects that tend to remit within a day or two in most people. The second one is that COVID-19, that if you get the virus, that natural immunity is better than the vaccine. And what we're becoming more clear is that people who had COVID-19, for example, a year ago, may not be as well protected against some of these emerging variants, and that the vaccines do a better job. The second thing I'll just mention is if you get COVID-19, there's growing evidence of so-called post-acute COVID syndrome that can affect not only people who are hospitalized with severe illness, but also those who, were at home and had mild illness, but continue to suffer health complaints thereafter. The last one is, at least for Pfizer and Moderna, is that the mRNA vaccines will alter your DNA. RNA does not enter the nucleus. I call these vaccines Snapchat vaccines. The RNA essentially dissipates very quickly after entry into host cells. Those elements do disappear. The spike protein's made, the body reacts to it. So there's no potential for permanently altering your genetics.
Well, before maybe you go on to talking about herd immunity, maybe we could get one of these questions answered here that really had to do with the second one, which is the difference in protection from natural infection or natural infection plus a vaccine, and why it might be important to get the vaccine even if you got the original. That's both important for public health as it is now, but it also kind of peaks to the issue of boosters and what the natural duration of immunity is from natural infection, maybe from different kinds of vaccines, and when we may need to have boosters in the future. Can you elucidate a little bit on that topic?
Yeah, so I think it's a hard question to firmly answer. Moderna has published information that looks at 6 months post-immunization that immunity and the titers of neutralizing antibody seem excellent. I think in all likelihood, as long as the variants we know of now don't subsequently change, that we'll likely need to look at 12 or 18 months and see if we need either a booster of the current vaccines, or perhaps the spike protein motif will be altered. And that's easy to do with these mRNA vaccines, especially to just alter it to maybe fit a different genetic sequence for the spike protein. So Bill, I think maybe a year from now, we'll have a better picture, perhaps 6 months, on the need for boosters. Remember, you can still get COVID-19 despite being immunized. I think many people have this idea that they're 100% protected. The reality is probably you still have about a 10% chance of acquiring COVID if you're exposed to a high inoculum somehow. and and um, and as long as it doesn't make you severely ill, I think we're okay. But if those titers decline and more people not only have breakthrough but land in the hospital, I think that would be the tipping point for a third vaccine. Of course, the Pfizer CEO has predicted that you would need it after a year. I would view a conflict of interest there, perhaps. So I'll wait to see what some others who are researching this and following this along have to say.
Well, we won't go digress too far, but it does kind of, feather into overall immunization needs and requirements for the population, particularly the elderly. And so maybe you could just comment a little bit about its relationship with flu, both, what have we learned about the flu during this year? And can you see maybe how, if we need boosters or augmented vaccines, how they might be kind of programmed to work together, or at least in the minds of recipients, kind of do it once a year and get it over with type thing.
Yeah. Well, of course, influenza has disappeared. So has respiratory syncytial virus and most other viruses. I think it's rather remarkable that a lot of these less contagious viruses essentially have disappeared now for quite a while in the setting of the pandemic. I think the answer to your idea of whether this will become an annual event and so on is still hard to answer. I would say there are certainly people, the very elderly, people that are immune suppressed with organ transplant. We're admitting those patients now who have been immunized, but yet still exposed. So clearly, there are people that just don't mount very strong immune responses. That's not a failure of the vaccine. That's a host issue. But it's possible that third doses or perhaps a different strategy may be very helpful in that population. It's also possible this is a group that should get subcutaneous monoclonal antibodies regularly to really protect them, because they just don't really mount a sufficient immune response. So I think this will be an evolving situation. Some may be better off with those subcutaneous injections as long as community rates are high. If they're low, I think that would be great. And that's the hope, that most people will respond and that those numbers will go down. But as we started off, Bill, this is a global pandemic. And although we can do our best, it's sort of like measles. I mean, if we don't get high enough and lots of people come into the country carrying measles, you're going to have outbreaks. And I have a feeling we'll see this kind of COVID-19 effect probably for a couple of years yet. And it will very much depend on how many people in a given area are immunized, and as well as on an individual basis, how well they respond to the vaccine.
Mm-hmm. Well, we kind of backed into your next slide, which is about herd immunity. So obviously it's kind of a puzzle here where things are, both the vaccine rates and the variants that are coming through, as well as the durability of effect, of immunity, all kind of tying together. Love to hear what your thoughts are on the herd immunity side of that.
Well, this is a little graph that was looking at, for example, the United Kingdom and the United States, both of which have sort of been off the mark far faster than some other countries that have large populations. And the thought is that hopefully by the third or fourth quarter, we'll get to that 70 to 90%, which is clearly an estimate of people who have been immunized or sufficient natural protection, such that community rates will get to that yellow or green spot that you saw earlier on the map. I think the variants have thrown a curveball just because they're so much more transmissible. The other issue here, of course, is that we're not immunizing school-age children. I mean, it's 16 and older at the moment, and that's a substantial population. They may not get terribly ill on average, but certainly they can transmit the infection. And again, there's going to be a small at-risk population of people that just don't respond well to the vaccine. And this is very similar to the influenza story, Bill. I mean, how do the elderly who are most at risk for influenza get vaccine? It's actually from the kids, which is why there's such an emphasis to immunize children to drive down influenza in the community pre-pandemic, at least.
Mhm. Yeah, well, that's a great time to bring in a couple of questions that are related to vaccination in kids. We have seen the age of vaccination uh, descend into at least adolescence, and the efficacy data there is pretty promising. But can you talk about the full spectrum of ages and what's likely to pan out in the months to come?
Yeah, so at the moment it's 16 and older, where the FDA has emergency use authorization of the Pfizer vaccine. Pfizer's presented 12 to 15-year-old data now, so I expect very shortly 12 and older will be a group that can be immunized. Both Pfizer and Moderna have proceeded with evaluating the vaccine in children under 12, and as well as the 12 to 15 for Moderna. So those studies probably are going to take through the summer, so it'd be more in the fall. And I don't think people expect elementary school children, for example, will be immunized before the start of the year, just the way the trials have been organized and set up. But once that group does get more immunized, I think then those estimates of herd immunity will feel much better. But certainly getting adults immunized is important. I think there'll still be social mitigation in schools, unfortunately, until those community rates are low. Perhaps we'll be surprised and they will lower faster than we wish, but that's why you sort of see the third quarter here to fourth quarter as being the more likely where we might achieve those kind of herd immunity rates that will allow the COVID-19 infections in our towns and so on to fall substantially.
Mm-hmm. Well, there's so many questions out there. I have time for just maybe one or two more. And again, thank you to everyone who has submitted questions and engaged with us. As you know, Paul and his team at Johns Hopkins are the authors of the Johns Hopkins Antibiotic Guide, as well as the HIV guide, diabetes, and psychiatry guide. And within the antibiotic guide, there is regular updates on both COVID and the vaccines that we've been talking about. And that's been a really important source of keeping up to date. And we thank you for that, Paul, for nights and weekends on top of everything else you're doing, keeping us at the cutting edge of everything going on there. I guess one of the last questions would be about what some people are calling long COVID, but more in the parlance of medicine, post-acute COVID syndrome, and what we're learning about it, and obviously how that ties into vaccination and the motivation for not just avoiding the illness, which can be bad enough, but the post-acute syndrome.
Yeah, so Bill, in some ways there's a resemblance to other post-infectious syndromes after infectious mono, after Lyme disease, for example, if you're in Australia, perhaps after Ross River Valley infection, or even Q fever. About 10% of people in those instances developed something that had similarities to chronic fatigue syndrome. Some people call it myalgic encephalitis or fibromyalgia. However, there was a recent study called the COMET study in France, and also a very large observational study in the VA system, of course, looking more at older men. But what struck me from both of those is the substantial amount of health problems in the 3 to 4 months afterwards, including in people that were never hospitalized. For example, in the VA study, the need to seek medical care was 20% more than people that did not have COVID, and the mortality rate was 60% higher in the group that experienced COVID, which I think was just remarkable versus those that didn't. And very similar issues were also occurring in France. So I don't know if we can really blame the health systems per se, or lack of attention and so on. So I think this just adds even more to the rationale for getting the vaccine because we're still learning about health risks that this very fascinating and terrible virus does to our immunological responses and perhaps other responses that really adds a great deal of complexity here that we're just beginning to unravel. And I think we have a long way to go.
Mm-hmm. Do you see that institutions like yours will specialize in this area, or do you think it is close enough to other syndromes to be addressed in other ways?
Well, certainly I have a sense that the NIH and others are organizing some substantial research increases in this area, and perhaps will give some insights. I think it's probably a heterogeneous disorder amongst heterogeneous populations. It's probably not just one thing, but it's been very difficult to understand why these items strike down very healthy people, and they're just have different health 6 months after apparent recovery from illness. And of course, this doesn't happen after rhinovirus, but it does with some bacteria, some viral infections. So I'm hoping this will be a little bit of a Manhattan Project for post-infectious fatigue syndromes to try to understand the pathophysiology, because otherwise we're borrowing treatment approaches from our colleagues who handle fibromyalgia, or have physical therapy and graded exercise and other items there. So it's an area that I think has been under researched. In fact, there was a bit of a scandal years ago that a lot of funding for chronic fatigue syndrome that was appropriated by Congress was never really carried out. So this is now a time where hopefully this will yield something like Teflon we use every day when cooking was part of the space program. So I'm hoping that quality researchers will be attracted to this field, but it's been very frustrating, but money is is very helpful to stimulate interest.
Yeah. Well, if we've learned anything from this pandemic, it is both the race and the race we're in with nature, and not just in trying to outrun it in certain places, or at least keep up with it, but also how to find out what's going on under the covers, so that we can have insights not just for those patients, but for ones that suffer illnesses that are very similar. And so that should be a fascinating and very important area that I guess we're going to probably hear a lot more about in the coming months and years. The last question is kind of a Hail Mary, just because you're so good at articulating everything about infectious disease and here COVID. This is really more of a global question. And it's really about what do we face as a global community related to COVID? over the next few years? I mean, how is this likely to play out? And from what we've learned, do you see that there's opportunities? What are the big world global health lessons that we've begun to learn from dealing with this pandemic?
Well, Bill, that's a huge topic, and I guess the way I would try to answer that is first, I think certainly immunizations are our only way out of the pandemic, and COVAX, which is a alliance of organizations, NGOs, to try to get immunizations to lower and middle income countries is going to be hugely important over the next 2 to 3 years. I'm very glad the administration here in the United States has joined in with that effort there. The second and the larger one is we have to prepare for the next one. I mean, this is our third serious coronavirus infection in 20 years. It's obviously the biggest compared to the original SARS and Middle East respiratory syndrome. But if it's not this coronavirus, it could be influenza, which everyone expected would be this case. But it's getting these organizations set up to respond better, and I think we'll have lessons learned. I continue to be surprised at the amount of discord and polarization in dealing with a public health emergency. I think trying to educate and learn from our past experience what might be most helpful, and trying to even incorporate it into regular educational directives, not only to our people in the country, but in schools would be very helpful, because I think we were starting from zero and then having to deal with this. And there have been approaches such as the hammer in China to very soft touches elsewhere. And again, people will debate what the right approach is. And clearly some countries have responded differently, and there's always costs to decisions. So these are the sorts of things that, just like I'm sure the military have done for years, exercises and tabletop exercises should become a routine moving ahead as part of our global health strategy, as well as dealing with climate change and so many other forces that are probably contributing in some way to the spread of this pandemic.
Thanks, Paul. You did that beautifully, given the scope of that question. One of the things that I think a lot about is, how this has taught us the limitations, particularly in the United States, of our disease-centric system, as opposed to a health care system, that we're really set up mostly for taking care of sick people and less so for keeping people healthy. And it'll be very interesting to see what lessons we take, the lessons that have been learned, and whether they become policy and ways for information sharing and the like that will allow us to respond better the next time. Well, thank you again for sharing your valuable time and your expertise. It's just been wonderful. Just before we end, letting people know again that Unbound Medicine and Johns Hopkins together provide the Johns Hopkins guides, and particularly the antibiotic guide, which is very relevant today, where this kind of information, including these webinars, are posted regularly. And if you have any questions for us, please reach out to us at the email webinars@unboundmedicine.com. Again, thank you, Paul, and hope you all have a great day. Thank you.
Thank you, Bill. Be safe and be well.